Welcome back to Clinical Challenges in the Management of Complex Patients with Type 2 Diabetes Mellitus, presented by the Albert Einstein College of Medicine at Shiva University Diabetes Series Live. You are tuned in to the live session entitled Understanding the Cardiovascular Effects of Antihyperglycemic Therapies with Dr. Darren McGuire. My name is Andre Peixau. I'm a cardiology fellow at University of Texas Southwestern Medical Center. Before we get started, I would like to remind you that today's session is a live interactive program that allows you to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them into the box located in the lower left-hand side of your screen. I would now like to introduce our presenter, Dr. Darren McGuire, Dallas Hartbaugh Chair of Research in Heart Disease in Women at the University of Texas Southwestern Medical Center. Welcome, Darren. I'll now hand the program over to you.
All right, thanks, Andre. Well, welcome to the program. Before we launch into the presentation, I'd like to make just a couple of disclaimers. First, I'm a cardiologist and not an endocrinologist, and I think that will become pretty evident quickly into the presentation. Secondly, everything we're talking about today will relate to type 2 diabetes only. We won't be talking at all about type 1 diabetes. And finally, this entire presentation today is off-label conversation, as no drugs for the treatment of hyperglycemia are presently approved, indicated, or have a claim for cardiovascular risk reduction. So with that introduction, we'll launch right into the presentation. So why are cardiologists interested in diabetes? Well, these data from the UKPDS, the United Kingdom Prospective Diabetes Study, from almost a decade ago, show us that cardiovascular risk eclipses microvascular disease risk in patients with type 2 diabetes. As you may recall, this study enrolled patients at the point of diagnosis of type 2 diabetes into a randomization to different glucose control strategies. In this slide, we're clumping all the patients in that study together, followed over about 10 years on average, and looking at the aggregate incidence of each of the individual endpoints: blindness, end-stage renal disease, amputation, and the net microvascular disease complication, which was less than 10% of patients participating. If you look to the right of the slide, you see that coronary artery disease, cerebral vascular accidents, and macrovascular disease composite are about 3 to 4 times more common than microvascular disease complications, begging the attention of the cardiologist, the generalist, and the endocrinologist to attack the cardiovascular risk. This is another set of epidemiologic data that represents the burden of type 2 diabetes represented in various cardiovascular cohorts. On the left of the slide, the study by Taubert. This was a study of about 3,200 patients coming to a cath lab in Germany for any indication, and in the pre-cath holding area undergoing fasting blood glucose testing as well as oral glucose tolerance testing. And what you see is about 18% of patients on arrival already had a diagnosis of diabetes, but an additional 15% of patients coming to that cath lab had a diagnosis of diabetes made just prior to the cardiac catheterization. This is important because cardiac cath data needs to be interpreted in the setting of type 2 diabetes or not. And so this study showed that 1 out of 3 unselected patients in a cath lab have type 2 diabetes. The next study by Muhlstein is a similar study in a percutaneous coronary intervention cohort in Salt Lake City, Utah. Again, about 1 out of 4 patients coming to the cath lab and having percutaneous coronary interventions. 1 out of 4 had diabetes previously diagnosed, but just looking at fasting glucose, almost 20% of patients additional from fasting glucose around the time of the cath were diagnosed with diabetes, raising the prevalence in that cohort of over 40%, showing the prevalence of obstructive coronary disease in patients with type 2 diabetes. The study by Norhammar, third one on the slide, is an acute coronary syndrome patient population in Stockholm, Sweden, where about 20% of unselected patients presenting to that hospital had a previous diagnosis of type 2 diabetes, but almost 1 in 3 undergoing oral glucose tolerance testing, almost 1 in 3 patients were diagnosed during incident myocardial infarction admission to also have type 2 diabetes, raising that prevalence to 50% of unselected heart attack patients. And finally, in the study on the right is an unselected cohort of heart failure patients in Barcelona, Spain, showing that about 35% of patients in that cohort had diagnosed type 2 diabetes, but an additional 15% undergoing oral glucose tolerance testing were identified. And again, in a heart failure cohort, 1 in 2 patients had type 2 diabetes. So this disease is common in all cardiovascular cohorts, and we have to better understand how to treat it. We've made a lot of progress in the treatment of type 2 diabetes and the overall population of patients for cardiovascular disease, but there remains a residual risk of type 2 diabetes. So after we've treated with antiplatelet therapies, blood pressure control, lipid management, we still have a residual risk in the contemporary practice of type 2 diabetes, increasing cardiovascular risk. On this slide are data abstracted from 5 fairly contemporary statin trials. And what you see here are the representation of the primary outcome event rates stratified by diabetes for the patients randomized to the statin treatment in each of these trials. So in the heart protection study, simvastatin 40 milligrams. In the CARE and lipid trials, 40 milligrams of pravastatin. In the PROSPER trial, also 40 milligrams of pravastatin. And in the ASCOT trial, 10 milligrams of atorvastatin. And what you see in each of these trials is approximately 50 to 100% increased risk associated with diabetes, even when prevalently treated with statins. So with this residual risk, it continues to raise the plausibility of intervening on the primary fundamental abnormality in diabetes, that is hyperglycemia. And although that remains a plausible hypothesis, we've not effectively proven that hypothesis yet with the existing data. Going all the way back into the 1960s, and this study published in 1970, the University Group Diabetes Project, was the first ever large-scale randomized trial attempting to evaluate the cardiovascular effects of glucose-controlled therapies. About 1,000 patients were randomized into this trial into one of 5 different treatment groups. You see about 800 patients reflected on this slide in 4 different treatment groups. That's because the fenformin arm of this trial was discontinued early, and those data have never been analyzed to my knowledge. So what you see on this slide is a first-generation tolbutamide in the yellow line, insulin variable, which is titrated tight glycemic control with insulin, insulin standard, which is effectively an insulin placebo, 5 or 10 units once daily of insulin injected, and truly a placebo was used in this early type 2 diabetes trial. And what you see is early in the trial at about 3 years and continuing throughout the 8-year follow-up, the yellow curve, the tolbutamide-treated patients had increased mortality. Now, we can't make a whole lot of this because there were only about 90 total deaths and about 60 cardiovascular deaths. So the precision of this, the statistical precision of this comparison is a little bit uncertain. However, suffice it to say, the signal was fairly robust and led to a product label warning for tolbutamide that oral hypoglycemic drugs may increase cardiovascular mortality. As surprising as that is, you have to recall that back in those days, tolbutamide was the only oral drug available and insulin was the only other therapy available for type 2 diabetes. So instead of withdrawing it from the market, simply a product label warning was placed. To the surprise of many clinicians, this product label remains in contemporary medicine for every sulfonylurea approved for use in the United States. Every single drug we're using today in the sulfonylurea class has this same cardiovascular warning in it. Then about 1 decade later, we finally had a ray of light, a ray of hope for intensive glucose control from the UK PDS trial. Introduced earlier, about 4,000 patients with type 2 diabetes newly diagnosed were randomized to more versus less intensive glucose control. And as you can see, the primary outcomes on this trial, on this slide, at the very top of the slide, you see the point estimate of a 12% statistically significant relative risk reduction for the composite aggregate outcome of all diabetes-related complications. Myocardial infarction in that trial actually went in the right direction, a 16% reduction in myocardial infarction that just barely missed statistical significance. But importantly, the next line, stroke, it went in the opposite direction, an 11% increased likelihood for stroke. Again, very few numbers of events and not nearly achieving statistical significance, but a signal in the wrong direction. And finally, as you can see at the bottom, the entire benefit of this trial was largely driven by the microvascular disease complications, a 25% relative risk reduction in the composite of microvascular disease complications. So at the very least, it looks like that tight glycemic control is at least safe for cardiovascular disease, and on the backdrop of microvascular disease risk reduction remains evidence-based therapy.